So there we are, some excellent presentations showing the real depth and breadth of hip presentations and diagnostics and interventions that are possible, of course, across all the ages. So a fascinating area that we all must continue to learn from. We've got plenty of questions already on the chat on the Slido, but do feel free to add more questions. And likewise, if any of the faculty feel they would like to add a comment at any stage, please let me know. Please do unmute and make a commentary, because you may all feel you have some views about what other people have said, because you wouldn't have heard those presentations before. Dr. McCormack, let me start briefly with you, because you deal with a very, very special group of people. Now, you mentioned that a lot of them have hypermobility and a lot of them have dysplasia. What do you feel is the interplay between the two? Is it that you can be a great dancer with one or the other, but if you have both, then you start to get potentially some problems, or is it much more complicated than that?
I think the combination of the morphology and the hypermobility can cause further problems. But if a dancer is from a very early age trained exceedingly well and has the support of physiotherapy, control, coaching, strength and conditioning coaching, and specific one-to-one coaching, you can make a very good dancer out of that combination. But it does take manpower. And that's where the dancer that doesn't have that support can fall by the wayside and be excluded from the profession. A lot of dancers they are injured very early on, and they go through a number of injuries, and they don't get up the ladder until a lot later when they have had a lot of experience, and then they finally make the top of the ladder. And then you look back at the training and you think, we could have done that earlier if they'd had the support. But it's manpower.
As with many things. I just wonder if we turn it on its head, both to you and John Hutt, maybe the problem of hypermobility per se, not in the dancing population, but in the general population. What can we learn from dance to help that population? Because I think the one thing we do know is they are a very tricky population who present with multiple joint problems and frankly have pretty awful results with surgical intervention. And do correct me, your surgeons on the call, if you think that they have good results. But my perception is even the hypermobility doctors often worry about these patients and what to do for them. So do let me know what you think we can translate from dance to general hypermobile people in the population. And John, be keen on your comments on that as well.
Well, I think there's a couple of things there. Firstly, I think Maura makes some very good points. Is that one thing we really struggle with in the hypermobile population is actually getting them access to the right sort of rehabilitation expertise. And I think often it very much depends on where you are. There's somewhat of a postcode lottery about the whole thing. And if you happen to be somewhere where you've got access to all of that, then the potential for your outcome, both from non-operative management and from surgery, to be better is definitely higher. I might just say that in my perhaps slightly more limited experience, one of the things that does work in hypermobility surgery is hip reconstruction surgery, if it's done for the right reasons. And I think there are lots of hypermobile surgeries that don't work, but I do think that one does work. Now, it might not. I think on its own, it's not enough to just return the hip to normal. But I think combined with good rehab, and it has the potential to be quite a powerful operation. I think one of the problems is knowing when the right time to do that is, because it is, a big intervention, and it is a big thing for people, both socially and, perhaps professionally as well. And that can be the very tricky balancing act, I think.
And how often is it bilateral?
I would say quite frequently.
And presumably you never do bilateral simultaneous, so you're kind of taking two episodes out It's a bit like the child having the holiday operation every year.
Well, no, and that's exactly what you have. And I have a number of teenage patients who have had exactly that. And it is 2 years of your life. And it isn't really that easy to speed it up. I mean, in the adolescent with their healing potential, you can argue you could do it slightly quicker, but there's only a limited amount to which you can close that window.
That's great. Thank you, John. Moira, sorry, we lost you there for a second, but probably for me, the key thing I want to learn from you is what can we translate from dancers very easily that we can give to the rest of the population? You've got this amazing group of people with phenomenal self-control, phenomenal skeletal control, strength, commitment. They're remarkably hardy, as well as the fact they perform beautifully. But what can we take from them to teach the rest of the population?
Excellent proprioception and the training of that from early on.
Very good. So proprioception, excellent. All righty. Let me jump on to another question, and this is to Ricky, John, and Alistair. There's been a couple of questions on the chat about MRI scan imaging, and in particular whether we need contrast and whether we need arthrography. So Ricky, maybe let's just recap for imaging the groin, if you like. You clearly need a groin specific scan, but do you need contrast? You clearly probably don't want arthrography, but keen to hear from you on the ideal imaging. And one of the questions we've got here is what's your threshold for imaging? For what do you need to see in that patient in order for you to get an MRI scan?
Yeah, I think in terms of the contrast question, the MRI scanning now with the specific groin scan is not needed. In terms of the presentation, it comes down to the patient specific. So if it's an elite level athlete, I think any mechanism of injury suggesting an adductor injury or inguinal injury deserves an MRI scan, because as we've shown with the literature, early treatment with either surgery or rehabilitation is key to get a good outcome. In the general population, I think obviously presentation with bruising, significant bruising in that area and a mechanism of injury should really warrant further imaging with either dynamic ultrasound or MRI scan, whichever is easily available. Depending on the patient, you are going to see some delayed with chronic pain groin syndrome, just due to the delayed onset by seeing a GP or physio at a later date. I think in those patients, if they have continued groin pain, then MRI scan after a period of physiotherapy and analgesia, usually around that 6 weeks to 3 months mark. If it's not settled by that point, they really warrant further imaging.
While we've got you, Ricky, and you're talking through imaging, the plaque concept has introduced the sort of structures injured. There's been some classifications put forward around that. Do you find them useful, particularly in your management, in terms of deciding when to do what?
So I think in terms of the plaque type 1 injury, in the elite level athlete, if it's a adductor avulsion mainly, and it's got retraction, then that's going to be the defining decision in terms of surgical repair. The interesting concept with plaque injuries is looking at whether there's a inguinal disruption and rectus abdominis injury. And that's only really picked up by the further imaging with MRI scan. So those types of injuries definitely do need further treatment and specialist opinion. So there is definitely some help with that plaque type classification, depending on whether you need to involve general surgeons and orthopedic surgeons as a sort of joint operation to make sure that you deal with both injuries rather than just the adductor injury.
Very good. We'll come back to the MRI in a second. There's a question for you here about return to sport criteria, because someone thought it was quite quick at 10 to 15 weeks, although Actually, that's been my experience. Do you have any commentary? What are the return to sport criteria, presumably other than range and strength?
Yeah, so in the literature, it really is, even in the non-operative management, in the sort of systematic reviews, it is around that 12 to 16 range. But it's all down to rehabilitation going through the different phases. So early recovery, protecting, and then light load, going on to higher loads, and then return to sport activities, all without pain. So it really relies on that. If you hit a certain milestone and you've got some pain, you have to take a step backwards and potentially re-image at that point.
Okay, thanks, Ricky. That's helpful. Let's go back to John and Alistair on the MRI's question. People are very intrigued by either getting an MRI or an MRI arthrogram, and keen to get your sort of further perspectives on that, because there are passionate believers in MRI arthrography, and likewise there are people who never wish to subject our patients to that needle. So who wants to go first?
Should I?
Yeah, please do. Please do.
So I think, well, first thing to say is I don't think MR arthrography is a benign procedure. It has pain associated with it. Patients almost universally report it as an unpleasant experience. So I think we have to really justify what we're gaining by putting patients through that. And generally, the belief is you get a higher pickup rate for labral tears. Now, I think there's two reasons why that's probably not worth the cost and the pain. One is that it very rarely changes our management plan. Indeed, we tend to use MR imaging primarily for the exclusion of other causes, and indeed to assess the chondral surfaces, rather than specifically looking for the presence or absence of a labral tear. And also, I think as technology evolves and advances, higher magnetic field imaging, so 3 Tesla MRIs, are better at picking up labral tears without the need for contrast as well. So in my practice, there is no role for MR arthrography. And I don't think that the additional information it brings has any bearing on my decision making, so I wouldn't recommend it. So in a nutshell, I think I'm very much MRI only.
That's helpful and really clear. John, any different from you? I wish all the radiologists were listening.
No, I mean, I think that's very clear. And I think I share very much the same beliefs. And I think we know from our MDT imaging that the quality of the imaging you get is as dependent on the way the scanner is set up and the way it's protocoled as it is about what you do with the scan. So I never get MR arthrograms at all. I wonder if you wouldn't mind, Faz, I wanted just to ask Ricky, actually, while we were talking about the groin injuries, and we obviously, there's quite a lot of coexistence of hip pathology, groin pathology, and, and I think, there's a lot more understanding about the sort of plaque and adductor level, but this sort of inguinal disruption, Gilmore groin question is very interesting to me. And I just wonder, are we at a stage where you can actually define that in more than just in a clinical sense? Is there imaging modalities you can use that define this entity, or is it really just still clinical suspicion and chronicity of pain?
Great question.
So I think looking at the literature, the imaging protocols are still not picking up the inguinal canal disruption. So all of the literature basically is operative findings. So they've gone in with a chronic groin pain syndrome patient, usually an athlete, because they're the ones most high demanding. And they find a rectus abdominis injury, they find transverse abdominis injury, which is disrupting the posterior inguinal canal, or the anterior inguinal canal with the aponeurosis from the external oblique. So generally, I think they've picked up on this sportsman groin or sportsman hernia term and grouped everyone together, when actually some of them were a plaque injury, some of them were a sort of anterior inguinal wall injury. So I think it still comes down to examination and diagnosis of an inguinal problem rather than an adductor problem. You're probably not going to pick that up necessarily on the MRI scan, and then it's about deciding with the athlete whether you go in to potentially repair the inguinal canal and maybe the adductor on top of that if you found that on the MRI scan. But yeah, still a difficult area in terms of whether you picking it up on MRI scan. I'm not sure it's that sensitive still for the inguinal canal, especially.
Ultrasound, Ricky, does that, with inexperienced hands, or is it still the clinical presentation?
Yeah, there's a little bit on that in the literature in terms of all the radiology papers mention dynamic ultrasound, but that is still very operator dependent. So I think if you have a very good musculoskeletal radiologist, they can pick up these tears in the posterior wall and anterior wall and give you a better idea what you're dealing with before potentially going into an operation.
Very interesting. Let's jump back onto the hip. Two questions here people were keen on. One is the influence of REDS on injury occurrence and recovery timelines. I guess both for John, Alistair, and maybe Ricky as well, in terms of that impact, if you're familiar with it or not. You may not feel it's something. And what about the impact of obesity or BMI on hip pathology?
Well, I certainly would have thought that individuals of a raised BMI are generally at risk of increased pain from the whole array of hip pathology. And I certainly think it does have a bearing on surgical management. So if you take, for example, the periacetabular osteotomy, one's rather concerned about undertaking that type of surgery at the extremes of BMI, both high and low. Low for the risk of bones not going on to heal and the risk of stress fractures, and high being issues with fragment migration and also surgical access being challenging. I think hip arthroscopy also has some issues with access. In the very large patient, it's extremely difficult to access the joint through a very deep soft tissue envelope. So I think that has to be part and parcel of the management of any of these patients, is consideration of weight loss and whether there might be a role for some of the modern pharmacological agents being used for that prior to consideration of more invasive things like surgery.
Yeah, no, and some of the agents are now coming to the UK. Some have been validated, so I think we're going to see a lot more of that. Ahmed, is the flip side of what you talked about, but there was a period of rationing in this country, certainly in certain regions, for BMI over 35 for joint replacement. So those aren't the population you were talking about. What's the situation now? And should there be a limit? Should we be only intervening for patients of a certain BMI?
I think everything has to be taken into context. If a patient is struggling to cope, despite the best efforts of having gastric surgery or weight loss, and they become immobile, one should be offering them surgery for arthroplasty. But it's a difficult situation for patients, and it's got significant socioeconomic impact on the NHS as well. So in my practice, if a patient has attempted to lose weight and they fail to lose weight, through an MDT approach, I will offer them surgery as long as all other avenues have been exhausted.
Fair enough. That seems reasonable. While we're on you, Ahmed, somebody here has asked for contact sports after arthroplasty. So, for example, if someone's getting back to football or rugby, how quickly do you think they should do that?
So, returning to sports is a personalized rehabilitation program for each patient. And what determines how soon they get back to what their pre-injury or pre-arthritic activity levels were. If they were high-end sports and they will intervene early, most likely they'll be able to go back within 3 months. There's no limitation when they can return. As long as they recover from surgery, they gain back their muscle strength, and they got muscle function and proprioception, they should be able to engage sports as soon as that individual is able to do the activities. It's almost like goal-based approach for following hip arthroplasty. So
you don't worry about soft tissue healing or bony healing?
The pain and the patient's symptoms will dictate when they get back to sports. So if this patient is able to swim at 2 weeks or 3 weeks, we let them swim. And at 6 weeks, they're able to get back to activities. We continue to let them get back to sports.
Very good. All righty, let's transition back. Somebody here has asked about ligamentum teres. injuries. I don't know whether Alistair or John wants to take this one. Type 1, type 2 ligamentum teres injuries. Can we manage them non-operatively? What should we be doing for them? And when is surgery required for ligamentum teres injuries?
So I'll chime in a little bit on this. I think that you know, the ligamentum teres probably isn't in and of itself a major stabilizer of the hip, but I think it can be like a sort of a signal. And I think that if you are finding that you're getting reports in your MRIs that people have ligamentum teres tears, which I think are a very common thing in hypermobile, high range of motion athletes, it's perhaps just another sign that there's some instability in the hip. So I guess you can't really answer the question, you know, whether you treat them non-operatively or operatively, because I don't think they're an isolated phenomenon, and I don't think they're necessarily painful in and of themselves. But if you've got somebody with recalcitrant hip pain, and that's the bit of information that you have, then it should prompt a search for, you know, other causes of instability and treatment down that line. I've never done a ligamentum teres repair. I often wonder whether if I did a PAO, a labral reconstruction, a capsular reefing, and a ligamentum teres repair in all my patients, whether I'd get them more stable or less stable. But at the moment, it remains a theoretical possibility rather than a practical application.
I remember Ricky Villa made us spend lots of practicals practicing it. So I'm sad that I'm sad that your generation hasn't adopted what was an operation looking for an indication. So. Very tricky. Otherwise, just checking with the audience. If you have more questions, please do put them down. Otherwise, I will keep quizzing them with stuff that interests me and not necessarily that may interest you. Moira, what's your perspective, and linking in with what Ahmed was talking about, with your dancers who manage remarkably well with hip abnormalities, if you like, and then hip pathology, eventually caving in and getting degenerative disease and needing hip arthroplasty? How do they do in terms of their dancing?
I don't have an experience of a dancer who's had hip arthroplasty and gone back with replacement or partial replacement. I don't have that experience. Most dancers try and keep going on till the end, even though they've got chondral damage. Once they're experienced dancers, they manage to compensate amazingly, and they push the retirement date on and on and on. And then once they've finally got to the end of their career, they give up and start to really look after themselves. And my experience of the last one was, yeah, I thought she'd end up with a hip replacement, but no, it's all settled down. She's doing all her exercises. She still comes for physio, and that determination carries her on. I think probably another 15 years she might need something, but she'll probably look after herself now that she's not dancing.
That's interesting. I mean, the Hospital of Special Surgery are about to publish their experience in the dancers in New York, and actually it's very positive. You know, some back to performing, some with resurfacing, some with replacement, doing very well. I think that's out in the March BJJ. So it'll be really interesting to see. So there are some who do, and I've certainly experienced a couple who always surprise you with how remarkable they are. That's very good. Ricky, bilateral injuries. How common? How do you deal with those? You know, those athletes who come in with those bilateral groin disruptions.
So again, they seem to be the more severe injuries, and we now know from the plaque type injury, the fibrocartilage does bridge across the symphysis and potentially having an injury across onto the other side. They are still the rarer injury, but I think if the imaging is picking up on both sides, then you do have to plan for repair with potentially suture anchor and suture repair on both sides. Otherwise, there does seem to be that imbalance of muscle forces across the pelvis, and some people talk about if you have an injury to the adductor, then obviously it's going to put more stress on the tilt on the pelvis, and you're going to get reciprocal muscle injuries and a muscle strain and edema on the opposite side and in the rectus muscles as well. So assessing it and seeing how severe the injury and potentially repairing both sides, but I still feel that is one of the rare injuries that we see.
Interesting. There's also, and again, this is slightly niche, but there's a vogue now for repairing the fibrocartilage and releasing the adductor all in one go. What's your take on that? There's been a bit of work on that from Finland, and seems to be vogue for doing it in some centres in the UK. Yeah,
so I think that again has come down to this idea that the pelvis tilting because there's overactive adductor compared to the rectus. I'm still, after looking through all of the literature extensively, saying that that's a missed certain plaque injury. So you've missed the rectus injury or the transverse abdominis or internal oblique injury. And so you're getting this overexertion or imbalance on the pelvis and sort of a fatigue type problem. So I think that's a sort of missed injury, and so they're unnecessarily releasing the adductor when they should be repairing more proximally the injuries from the plaque.
Okay, very, very good. Thanks. I think this is for you, Mauro. This has just come in. What's your favoured objective outcome measure? And maybe John might want to pipe in on this, for hip instability. In other words, for demonstrating that you've resolved someone's hip instability, or that it's better or worse for that matter. What would be your key test?
It would be being able to get through the whole vocabulary of the hip, the movements of the hip, without pain. And all the balance mechanisms in place, all the range of movement returned. And if the dancer is going back to specific choreography, then that specific choreography has to be achieved before the dancer is allowed to actually perform. It would have to be pain-based.
Okay. John, maybe for the simple orthopedic surgeons in the audience who can only do one test or can only cope with one test, is there an apprehension test, or is there another test that you kind of rely on to look for instability, or is that all outdated and is it all much more complex now?
I think that there was a point where the litany of young adult hip examination contained about 400 tests, and I don't think any of them were particularly specific. I actually only rarely use what you might call an anterior apprehension test, because it's actually quite challenging to do properly with the patient on the edge of the table, extending and externally rotating the leg. I don't find it adds an awful lot to the picture. I think I kind of accept that a lot of hip pain for non-arthritic and even arthritic causes behaves very similarly on examination, and in and of itself, apart from some of the range of motion information, which I do think is very helpful, it doesn't necessarily allow you to define what you're going to discover on your imaging. One, I think, area in which that's not true is if they're unless they're very hypermobile, in which case actually this doesn't count, but people's differential rotation can be very helpful in looking at either impingement or instability patterns in the hip. So for example, at a very basic level, your femoroacetabular impingement patient will often lose internal rotation in flexion, either due to a large cam or actually, in fact, due to acetabular retroversion as well. You get a similar effect. Whereas, say, your unstable patient who has maybe high femoral torsion will maintain internal rotation in flexion and lose external rotation in extension because of the kind of differential impingement that you're getting posteriorly. So that sort of thing, I think, is quite reliable at giving you clues, if not perhaps being a test that points you in one direction or the other.
Helpful. Alistair, do you agree, or anything from your end?
No, I entirely agree that the challenges of differentiating between instability and impingement, though at the ends of the spectrum can be quite clear, there is a very grey area in the middle when the diagnostic conundrum of whether what you're dealing with is actually borderline instability or a subtle form of impingement can be very difficult to tease out. And that can be really very challenging and involves thinking carefully about the history, the examination and the imaging, and trying to put all that together. And indeed, we very often discuss these types of complex cases in a multidisciplinary manner, which we find to be extremely helpful in trying to define the pathology and derive the best treatment plan for patients doing that. So I would strongly recommend discussion of these complex cases in a group.
Very good. A couple of questions just come in for you, actually, Alistair. Is the hip labrum mostly aneural, hence asymptomatic, or is it never the pain driver? Or indeed, is it a pain driver, but just there's an underlying cause behind it?
Well, I think the labrum is key in terms of as a pain generator, though equally it is not the cause. So I think, you know, you must look for why the labrum is torn. And I entirely agree with what John said earlier, that the referral for labral tear, you know, please see this patient, doesn't really get us much further, because an MR will commonly pick up a labral tear in an entirely asymptomatic individual, and it may be nothing to do with the hip at all. But I do think in the right patient who's got active impingement or instability, both of those irritate the labrum, and I do believe that that can be the pain generator. One quite clear example of that is in the dysplastic patient who's got to, let's say, their 20s with pretty minimal pain. Their bony morphology hasn't changed since their bones finished growing, but why didn't they have pain until suddenly one Tuesday when they're 24 they start getting pain? And I believe that that's the hypertrophied labrum, which has grown in size in order to try to compensate for the lack of bony coverage, eventually tearing. And that's what the sort of herald moment when a patient who will have had abnormal bony morphology for a long time will go on to develop pain. And common sense would dictate that, therefore, injury to the labrum may be a painful process, though there's not as much evidence to support these views as we might like, though I do think it is critical in the pain generation, but not in the actual cause of the pathology.
Now, so while we're on pain generation, I'm intrigued. We're coming to the close of the football transfer window. You know, footballers up and down the country are going into MRI scanners for several hours, having hips, knees, ankles scans. They almost universally have cam lesions, some chondrolabral damage, usually have labral tears, terrible pubic degeneration, and yet these are functioning almost as highly as Moira's patients. And so why is that? Why is it that these guys function, or girls for that matter, but primarily I think the impingement picture we're seeing in the guys, why is it they function so well with it and others don't?
Yeah, that is one of the great unknown unknowns about these problems. Some people can have a tiny area of very minor chondral damage in their hip, which causes terrible life-altering pain, and other people can have, you know, florid degenerate disease, labral pathology, and just sort of carry on. And I think that's because we don't really understand the pain generation and how the brain is modulating that as well as we need to be able to sort of unpick that. I think, John, you were about to come in when I jumped in there. Sorry.
No, I think you're right. I don't think we have all the answers to this. I mean, I think that I'm obviously relatively much more simplistic about this and movement than Moira is, but I think, you know, she makes a very good point that, you know, it's. I think the reason for that often is these are pretty well-conditioned athletes. I think their muscular strength and balance is good. I think their coordination is good. I think their proprioception is good. I think their movement is good. And I think that I sort of try and explain it to my patients sometimes when they say, why are you sending me for physio when there's a problem in my hip? And I say, well, look, you know, the problem is in your hip. Your hip is becoming inflamed through movement. But if you can get better control over your movements, you will get less pain. And this is, I think, why physio works for degenerative disease. So I think there's something in that. It's certainly isn't the complete answer, of course. But you know, why one person's hip with the same pathology, even in the same situation and the same morphology, hurts and the other one doesn't, I couldn't really fully explain, I'm afraid.
No, helpful, because that is a tricky thing. We almost don't comment on the hips when they look like that because we just expect them. Ahmed, moving on to you. It's first of all, this buzz around the anterior approach. I know you covered a number of aspects in your talk. Does the anterior approach actually make any difference to people's ability to get back to sport?
Having looked at all the literature that's been published recently, of all the outcomes, no difference between posterior and anterior approach in terms of return to sports. However, they report early function, early rehabilitation in the first few weeks, but at 3 months, there's no difference between the anterior approach or posterior approach. They equally just do as well. The key predictors of these patients who engaging in sports is what they were doing beforehand and how well they've recovered following their rehabilitation.
Brilliant. That's good. That's helpful. There's a brilliant question just come up, which how do you manage the infected joint after joint replacement with repeated arthroscopes to clear the infections when patients not responding to IV antibiotics? So I thought you'd like that, Ahmed, and you should take that on. Is there any role for hip arthroscopy to clear arthroplasty infection?
I don't think there's any role, and there's not much evidence surrounding that. It's best practice to get an aspiration or a biopsy. Maybe you can do an arthroscopy to get a biopsy or to get joint fluid. Otherwise, the standard practice, you aspirate and then you plan the operation depending on what the bugs has grown. If it's an emergency, then you can always wash the hip joint and get specimen. If it's within 6 weeks, you can do a day procedure where you try and retain the implants and change the modular components to it. So you would not, in a standard practice, use a hip arthroscopy to do with infections.
Helpful. Hopefully that's an answer to the person who must have a person struggling there to ask that question. So I hope that helps. Actually, John and Alistair, while we're there on arthroscopy after joint replacement, is that something that has a role in your practice for foreign body, psoas pathology, diagnostics, biopsies? That'd be pretty quite interesting to some of the people on the call.
Yes, I'll take that one. Well, at least in my practice, I definitely think there is a role. I think when you're obviously not dealing with an obvious other cause that you can find out from your imaging about a problematic arthroplasty, I would say there's 3 useful things that I find that you can do with an arthroscope. Perhaps the sort of more generic one is you can examine the implant, you can look at impingement, you can see what's going on during a range of motion physically and see if somebody is, for example, generating impingement and metallosis at a low level. I actually use it mostly to deal with psoas pathology, and I think, again, there's 2 things it can do. It's one, it can really allow you to examine the front of the hip and look for a prominent acetabular component as a cause in a way that sometimes the imaging isn't always that clear. And I think you can release the anterior capsule and the psoas in the appropriate patient. And it's not always appropriate to do that, but in a well-orientated implant that's buried within the bone who has recalcitrant psoas tendonitis, I think that patient actually can do quite well from what is, not so much a release, I suppose you might call it a lengthening at the level of the socket. So that I think are the 3 sort of things that I find it useful for when there's actually a joint in.
Thank you. Alistair, well, since we've heard about the psoas, there's a question here about iliopsoas irritation and symptomatology. How often is the iliopsoas a primary issue and how often is it a secondary manifestation? Because lots of patients have psoas type symptoms.
Well, I think it is an instability type issue, as we heard a little earlier. If the hip is anteriorly unstable, then you can have overactivation of the iliopsoas as a secondary restraint to try to keep the hip in socket. I think it's rarely a primary issue in these situations. There's usually something else driving it. I think I noticed in the question, there was a question related to how you differentiate iliopsoas irritability from labral tearing, which is very, very challenging. I mean, you can look at resisted hip flexion, which may give you some indication if the psoas is weak or irritated. And the issue with a number of these tests is that they are not very specific, so it can be extremely challenging, which is why, of course, you have to use your imaging findings as well, and often actually intra-articular or steroid injections into the tendon sheath can be very good differentiators in that challenging situation as both a diagnostic and therapeutic modality to try to investigate and manage these types of problems.
Helpful, very helpful. All right, well, I'm mindful of the ticking clock and people's dinners and drinks. I think we've heard 5 wonderful presentations across really the full spectrum of hip presentations, groin presentations, and hip disease. So I'm very, very, very grateful to Moira, to Ricky, to Alistair, to John, and to Ahmed for taking the time to both construct and pre-record those presentations, which meant we didn't have any of the glitches we see on other webinars, but also for joining me and teaching me this evening. It's been wonderful. So thank you all very much indeed. I know there'll be people out there who are too shy to ask their questions tonight, so feel free to get in touch via ISEH with via Becky at ISEH, and any of the speakers will be more than happy to address your queries or any other hip or groin related queries. Otherwise, thanks very much to all our speakers. Thank you for the coordinators, and thank you for our audience for staying up and asking such challenging questions. So thank you very much, everybody, and have a lovely evening.